Thank you for joining me for this chapter summary on coding compliance and clinical documentation integrity. Clinical documentation integrity is also referred to as clinical documentation improvement, and it's a process to facilitate the accurate representation of a patient's clinical status in the patient health record that is then transformed into coded data. Information is collected from the patient's health record and recorded as the codes representing the diagnoses and procedures performed. This information is then utilized for many purposes in healthcare. CDI programs initiate concurrent and retrospective reviews of health records for conflicting, incomplete, or non-specific provider documentation. The first and ultimate reason for excellent documentation is improved patient care through clear communication between providers and an accurate picture and the creation of, the accurate picture of the patient's medical situation and course of treatment. Additional examples are for accurate reimbursement and data reporting through programs dependent on diagnosis and procedure code, such as your MSDRGs, your value-based purchasing, quality of care measures, including inpatient quality reporting, the severity of illness, the expected risk of mortality, hospital-acquired conditions, or other patient safety measures. CDI goals. So the goals of CDI are to initiate concurrent and, as appropriate, retrospective reviews of health records for conflicting, inappropriate, and non-specific provider documentation, as I mentioned before. Key organizational stakeholders are involved in setting additional program goals. So the concurrent review of the record occurs while the patient care is ongoing, and often the reviewers are alongside the healthcare providers in the patient care service areas to facilitate communication. Retrospective reviews, on the other hand, occurs later once the patient has been discharged. So the goals of the reviews should be clearly defined by the organization embarking on the CDI process. Key stakeholders needs to be involved for a successful program, and they also need to be a part of that goal-setting process. So examples of key stakeholders in an acute care or integrated organization include the executive leadership, medical staff and provider leadership, health information and coding, compliance, risk management, finance or other aspects of revenue cycle, nursing, case management, utilization management, if I didn't mention them already, quality improvement, or patient financial services or billing, also known as billing. Operational considerations. So AHIMA suggests the following decisions must be made before implementing a CDI program to ensure the right people, processes, and technologies are in place. So who will comprise the CDI staff? How are we going to align the CDI program? You must determine the different types of records to review. Okay, so your record review, whether that be based on the type of record, inpatient or outpatient, the number of records, and the frequency of those chart reviews. We must also consider the budget, And then training needs, who's going to train? Where is training going to take place? Will CDI train the medical staff or not? And then let's set those benchmarks. Well, and if they are going to train the medical staff, and the reason why I say if is because some organizations are now contracting training for the medical staff. So if CDI is not going to train the medical staff, we need to identify who is going to train the medical staff. And then we need to create the scope of practice and then set some benchmarks. Set benchmarks for CDI, for the reporting, as well as performance monitoring. Okay, so the interdisciplinary team. Formal CDI programs using concurrent review teams can use a single disciplinary model, which is teams consisting of all nurses, HIM professionals, or physicians. Or they may use a hybrid, which is also known as an interdisciplinary staffing model, utilizing the skills from a combination of disciplines. Okay. Employer polls relating to CDI specialist education levels report hiring a mix of educational backgrounds. This suggests that organizations have evolved to the point of using a multidisciplinary approach. And whenever I talk about CDI, I mention the fact that I led a CDI team when I was an HIM director, and our CDI team consists of 2 nurses and 2 coders, and they cross-trained one another. And the model worked. It was an integrated model, and it worked wonderfully for our facility. Okay. And then that was the approach that we continued going forward. All right, so let's talk about AHIMA CDIP certification. So the CDIP was developed by AHIMA's Commission on Certification for Health Informatics and Information Management. We refer to this as CCHIM. Okay, organizations seeking CDI staff may want to seek candidates who have passed this exam because it indicates that they are knowledgeable and competent in clinical documentation, that they're able to demonstrate competency in capturing documentation necessary to fully communicate patients' health status and their conditions, and then that these folks are ready for leadership role. So AHIMA's CDIP certification supports the healthcare organization CDI process. And in the hiring process, the CDIP certification can be helpful in assessing what knowledge the applicants bring, in addition to any potential skill-based assessments during the hiring process. It's a development goal requiring continuing education and growth to achieve the certification for professionals working in the CDI process who are not yet certified, and it gives job seekers an advantage in obtaining a CDI position. So a CDI program may be housed in various areas in an organization, such as corporate compliance, health information management, quality improvement. However, each organization must evaluate where the location of CDI is the best fit. So in addition to a specific division or department being responsible for CDI process, I'm sorry. Welcome to the chapter summary for Chapter 9, Coding Compliance and Documentation Integrity. So clinical documentation integrity is also known as clinical documentation improvement, and it's a process to facilitate the accurate representation of a patient's clinical status in the patient health record that is then transformed into coded data. Information is collected from the patient's health record and recorded as codes representing the diagnoses and procedures performed. So this information is then utilized for many purposes in healthcare. CDI programs initiate concurrent and retrospective reviews of health records for conflicting, incomplete, or non-specific provider documentation. The first and ultimate reason for excellent documentation is improved patient care through clear communication between providers and an accurate picture of the patient's medical situation and the course of treatment. So additional examples are for more accurate reimbursement and data reporting through programs dependent upon diagnoses and procedures codes, such as your Medicare Severity Diagnosis Related Groups, which is MSDRGs. These are acronyms to know. Value-based purchasing, your VBP, quality of care measures, including inpatient quality reporting, IQR, severity of illness, which is your SOI, and then your expected risk of mortality, which is your ROM, your present on admission, your POA, or hospital acquired condition, which is HAC, your HAC reporting, or any other patient safety measures. So again, the goals of the CDI program or of CDI is to initiate concurrent and, as appropriate, retrospective reviews of the health record for, as I mentioned before, conflicting, incomplete, or non-specific provider documentation. Okay. Your key organizational stakeholders are involved in setting additional program goals. So really quick, let's talk about the concurrent reviews. So concurrent review of the health record occurs while patient care is ongoing, and often the reviewers are alongside the healthcare providers in the patient care service areas to facilitate communication. So your retrospective reviews occurs later after the patients have been discharged. So the goal of the reviews should be to clearly defined by the organization embarking on the CDI process. So key stakeholders need to be involved for a successful program and needs to be a part of the goal setting process. So examples of key stakeholders in an acute care or integrated organization may include your executive leadership, medical staff and provider leadership, health information management or coding and coding, right? Compliance, risk management, finance or other aspects of revenue cycle, utilization management, nursing, case management, quality improvement, or patient financial services or billing, which is billing. Okay, so operational consideration. AHIMA suggests the following decisions must be made before implementing a CDI program to ensure the right people, processes, and technologies are in place. So we need to decide who will comprise the CDI staff. We need the alignment of the program, right? How is it going to be aligned? Where is it going to be housed? Who is it going to report to? We need to determine the type of records to review, inpatient, outpatient, the number of records, as well as the frequency of reviews. We need to determine a budget for the program, and we need to consider CDI staff training needs, who will train, the location of the training, what type of training is going to be provided. We also need to think about CDI training the medical staff. Some facilities contract this, but most facilities don't. So that is a responsibility of CDI. So we need to think about their overall scope of practice. And then we need to think about and set some benchmarks. And then really, I want to say, hash out the reporting and performance monitoring. All right, so the interdisciplinary team. Formal CDI programs using concurrent review teams can use a single disciplinary model, which are teams consisting of all nurses, all HIM professionals, or all physicians. Or they can choose a hybrid, more interdisciplinary staffing model, which utilizes the skills from a combination of disciplines. So employer polls relating to CDI education levels report hiring a mix of educational backgrounds. So this suggests that organizations have evolved to the point of using an interdisciplinary approach. And for those of you who know me and know my background, at one point in my career, I did manage a CDI program, and our program consists of 2 medical coders and 2 nurses. Our nurses trained our coders, and our coders trained our nurses. The process, or this interdisciplinary approach, worked beautifully for us. So that is the model that I encourage. So let's talk about the CDIP certification. So the CDIP was developed by AHIMA's Commission on Certification for Health Informatics and Information Management. We refer to that as CCHIM, okay? So organizations seeking CDI staff may want to seek candidates who have passed this exam because this indicates that they are knowledgeable and competent in CDI, that they are able to demonstrate competency in capturing documentation necessary to fully communicate patients' health status and their conditions. And it also shows that they're ready for leadership roles. AHIMA CDIP certification supports a healthcare organization's CDI process. In the hiring process, the CDIP certification can be helpful in assessing what knowledge the applicants brings to the table, in addition to any skill-based assessments, which may also occur during the hiring process. So it is a developmental goal requiring continuing education and growth to achieve the certification for professionals working in the CDI profession who are not certified, and it gives job seekers an advantage in obtaining a CDI position. Alignment. So a CDI program may be housed in various areas, as I mentioned before, of the organization. This could include corporate compliance, HIM, quality improvement, or other areas, depending on the organizational needs. But it's up to the organization to decide where CDI fits best. So in addition to a specific division or department being responsible for the CDI process, an inclusive CDI oversight committee is beneficial to bringing together the multiple stakeholders identified in the previous section, including executive administration and the medical staff leadership. Even though the CDI process may not be initiated by a particular physician, service, or office, the support of the medical staff and leadership is just as important as support from hospital administration. With CDI, we are always or constantly talking about getting that buy-in, right, from physicians. So that's extremely important. Okay, so record review. In many cases, reviewing every record concurrently is not a feasible undertaking for a CDI team. Selecting the priority areas of service, patient care units, types of insurance, or other criteria that is high impact is often needed to direct the process. A retrospective review of documentation on accounts already billed in the past may help identify areas of need or significant impact to begin with. The goal is to obtain the most accurate clinical documentation that represents the patient's medical status and treatment received, not to target or exploit reimbursement programs. As for the actual documentation review, 7 items that a CDI professional will often need to obtain more specific documentation in order to meet the needs of accurate coding are suggestion: disease type, disease acuity, site specificity, disease stage, laterality, details needed to assign a combination code, or completely missing documentation. So the inclusion of descriptors is needed for the most accurate code and often needed before any code can be assigned. Is the fracture traumatic, pathological, or is a tumor malignant or benign? Disease acuity: is the disease chronic, acute, or subacute? So if we're thinking about site specificity, does the most accurate code require location, such as a specific lobe, distal, proximal, superior, or inferior location? So when we talk about the stage of a disease, we're thinking about how severe or advanced is that disease. When we refer to laterality, we're specifying the left or right eye, ear, or limb. I mentioned details needed for that combination code because many diseases and conditions are related and could be communicated with one code instead of multiple if specified as related in the documentation, such as diabetic complications, while others can be assumed related unless specified otherwise, like hypertension and kidney disease. So in this table, it outlines diagnoses and procedures prone to documentation gaps in the health record. So I specifically mentioned diabetes, but it also outlines neoplasms and specific heart diseases. The frequency of review. The organization will have to determine how many records are reasonable to be reviewed, depending on the size of the CDI team, the complexity of the records reviews, as well as the type of records to be reviewed in the target areas. The frequency of the record review depends on the individual organization, the bed size, as well as the number of CDI specialists on board. So depending on the individual factors, this could be every day, every other day, after admission and before discharge, or another interval as determined by the CDI team. Okay, so budget. Budgetary needs for hiring CDI, providing education, utilizing communication tools, and measuring, tracking, and reporting should all be considered. The composition of the CDI team, number and type of records to be reviewed, methods of education, communication needs, and information, and results tracking will vary between organizations. The number and types of records requiring review and frequency of desired review also impacts the budget for personnel as well as hours. CDI training staff. So both physicians and the CDI team need continuous education to stay current in regulatory, legal, coding, and external reporting trends. Because CDI professionals come from a variety of healthcare backgrounds and have strengths in different areas, it may also be beneficial to have a common orientation program for new team members to ensure everyone has the same understanding of documentation issues, and considerations. All right, so physician and healthcare provider training. The physician and healthcare providers should increase awareness of documentation issues. These include the many uses and impacts of documentation and coded data, where areas of improvement are to be found, and feedback on the quality of documentation and what improvements and benefits have been discovered. One of the benefits of having a physician champion for CDI is peer-to-peer insight in planning and facilitating training sessions. Basic metrics for CDI program evaluation. So the record review rate is going to be defined as the number of discharges reviewed divided by the number of discharge available for review. Your query review rate is defined by the number of records queried divided by the number of records reviewed. Your query response rate. Your query response rate is defined by the number of responses divided by the number of records queried. So these are some basic metrics, again, that every CDI program should be capturing. Additional metrics would be your query agreement rates. Your query agreement rate is the number of queries in which the physicians agree with the CDI staff divided by the number of responses. Your comorbidity and complication, CC, and major comorbidity and complication, MCC rates. Those are the number, or it can be defined as the number of MSDRGs with diagnosis codes for CCs and MCCs divided by the number of total MSDRGs. Physician clarification impact percentage. This is the number of queries initiated by a CDI team that had impact on the DRG divided by the total number of queries. And allow me to say, as great as it is to know these percentages and how to calculate them, there are several technologies and softwares that are available now that does this for you or for the CDI team. However, prior to implementation and during downtime, we must know how to determine these numbers. Okay, that's why I'm going over it. Okay, so severity clarification percentage. The severity clarification percentage can be determined by the number of queries that resulted in a severity change divided by the total number of queries. CDI productivity. Each CDI professional's individual results in the given metrics. The physician-specific query rate. Each physician's individual rate in the given metrics. Physician response turnaround time. Amount of turnaround time between the initiation of the query as well as the physician's response. And I don't want to say as well as. So the amount of turnaround time between the initiation of query and the physician response, right? How long did it take them to answer that query? And then if they don't answer that query, is there an escalation process or a follow-up process in place? Okay. Next is a CDI encoding agreement. So this is determined by the number of queries where the CDI team anticipated DRG matches the final coding assignment DRG divided by the total number of queries. This can be for a learning tool or not. Some facilities also refer to this as the reconciliation rate when the CDI reconciled with the coders. The baseline medical surgical case mix index, CMI. This baseline is set at the time of initial program assessment. So the actual CMI, medical and surgical, based on the population CDI program reviews, such as Medicare only, or all inpatient discharges, etc. You may want to exclude OB, newborn, psychiatry, rehabilitation, or more. Okay. And this is when determining the actual case mix index. So trending actual case mix index to goal case mix index. So this can break the trend into medical and surgical CMI, physician specialty service line CMI. Most healthcare facilities review CMI over time, both overall as well as by specialty. So DRG proportions or pairs. So you want to make sure that you review low and high DRGs and opportunities for DRG movement, such as from DRG 193 through 195, which is simple pneumonia, to DRG 177 through 179, which is respiratory infections and inflammations. The query process. So successful communication between the CDI team and the healthcare providers who are documenting care is identified as a key element to success. One form of communication is the process of asking questions of providers for clarification on documentation. The intent is to clarify what has been recorded, not to call into question the provider's clinical judgment or medical expertise. Developing a query. So as a result of the variation in providers' documentation methods, querying is a standard practice and a common communication and educational tool to advocate for proper documentation. The intent is to clarify what has been recorded, not not to question the provider's clinical judgment or their medical expertise. Situations where a query may be necessary include when documentation is conflicting, incomplete, illegible, ambiguous, or inconsistent. It describes clinical indicators without a definitive relationship to an underlying diagnosis. It includes clinical indicators, diagnostic evaluation, or treatment not related to a specific condition or procedure. It provides a diagnosis without supporting clinical validation. And lastly, it is unclear for present on admission indicators. So developing a query, it is wise to determine if open or closed-ended questions are most appropriate. Some situations are acceptable for closed-ended yes or no type questions, such as clarifying a cause and effect relationship between diagnoses, seeking agreement, or clarification between clinicians or reports, confirming details regarding established diagnoses, and determining if a diagnosis was present on admission. Either way, the goal is to receive the most accurate information and not to lead the recipient to a desired response. Documentation of queries. The documentation as a result of the query should be included in the patient record to communicate to other providers and to support the patient's course of treatment. This is often recorded in the progress notes, discharge summary, or addendum to the documentation. Each organization will need to determine if the actual query is a part of the permanent record or retained in other administrative records. Policies and procedures should be created to indicate if the query is a part of the patient health record, where it's located, and how long it's going to be retained. Involvement of compliance and legal departments can aid in determining the policy for each institution. Format of queries. Although the content of the question is more important than the format, some uniform format guidelines have been suggested. So we always want to make sure that we have, of course, the patient's name, the admission date and time, their account number, their medical record number, the date the query is initiated, the contact information of the CDI specialist, and the individualized diagnosis specific information relevant to that particular patient. So some query operational factors. In addition to the format or template of the query, other operation considerations need to be determined, such as the following: where in the records queries are placed, the process for notifying a physician that there is a query, standard procedures for how long a query is left open or unanswered before following up, what happens to an open query after the patient is discharged, who will monitor the unanswered queries, and any necessary feedback or corrective action to be taken and who will undertake it. Technology considerations. So while technology such as the EHR with the ability to integrate clinical pathways and provide real-time reminders to clinicians is helpful, it is not an automatic fix to documentation deficiencies. So while CAC, computer-assisted coding, processes can be useful in settings where documentation is structured and has a limited vocabulary, the content, including documentation of patient treatment inside the software and hardware utilized, provides the real benefit to patient care and the processes that support it. So, supporting CDI. Success depends on utilizing the right people, processes, and technologies. That matrix involves respect, communication, and relationships between coding professionals, CDI staff, and physicians with the support of leadership from administration as well as the medical staff. There's going to be some required resources for success. The need for predetermined policies and procedures for record review and queries. And then again, there's going to need to be metrics for building the business case for CDI initiatives. So let's talk about coding compliance. Compliance means complying with rules, laws, standards, or regulations. This is covered in more detail in Chapter 10. In addition to the inherent benefits of ensuring accurately coded data, the risk of negative consequences is also a driver for coding compliance plans. Fraud and abuse. Fraud and abuse are two terms often used to describe actions of a provider or organization collecting undeserved payments. Let's just say that. So fraud is an intentional deception or misrepresentation that an individual makes with the knowledge that the deception could result in unauthorized benefit to themselves or to others. Abuse describes practices or incidents that are inconsistent with sound fiscal, business, or medical practice and result in improper payments from Medicare. Regulation. So the False Claims Act is a federal law that seeks to protect governmental programs from fraud by individuals and companies. It outlines how both deliberate ignorance and reckless disregard to the truth or falsity of a claim are included with having knowledge of the false information. The Deficit Reduction Act of 2005 requires any program that receives or makes payments of over $5 million annually to provide education to employees regarding the False Claims Act. HIPAA. HIPAA was enacted in 1996, and it's a law regarding many aspects of the healthcare system. There are pieces that relate to coding compliance as well. So it's important to keep current on, developing regulations. All right, so there are many different audit programs regarding the accuracy of coded data submitted to federal agencies. The reviews typically include reviewing the documentation in the patient record and comparing it to the codes submitted on a claim for payment. So I am not going to define these acronyms for you. Some of them I have defined in previous videos, but I want you to write them down, and I want you to take the time to look them up to help you better understand what they mean. So that's a little activity in the midst of a video. All right, so I'm going to keep moving forward because remember, this is just a summary. Exclusions from government programs. So any provider or supplier who has been convicted of Medicare fraud or other healthcare fraud, theft, or financial misconduct is required to be excluded from any federal healthcare program. Okay, so those exclusions are significant as the government is the largest purchaser and provider of services in our country. So some auditing. When an auditor of a government agency or third-party payer is preparing to review records on site or through remote access, a notification of what records are needed and the method of the review is provided. In some cases, the auditors will select many records for review, and in others, a smaller sample. OIG guidance. The Office of Inspector General. Yes, I am aware this is one of the acronyms I've asked you to define already. But the Office of Inspector General recommends, well, let me start over before I talk about or provide the recommendations. The OIG was created in 1976 with the mission to protect the integrity of the health and human services programs, as well as the health and welfare of program beneficiaries. So different departments of the government have their own investigative agencies. Although the HHS OIG is larger than any other governmental OIG. The OIG publishes, guidelines that organizations are strongly urged to follow. However, they are not mandates because every provider is different and specific guidelines may not apply to every organization. So the OIG recommends written standards of conduct, written compliance policies and procedures, a designation of a chief compliance officer, regular compliance training, a system to report compliance issues, a system to investigate and correct such issues, and regular audits to monitor compliance. Okay. So each year, the HHS OIG publishes the projects that are planned and the areas identified for review. It is advisable to include the OIG work plan items that may be applicable to an organization in the compliance plan, as well as addressing other high-risk areas. So target areas include billing for non-covered services, inaccurate claims, duplicate billing, upcoding, unbundling, and overcoding. Okay, so compliance or coding compliance programs. So while compliance in general refers to meeting the requirements of laws and regulations, a specific compliance plan related to coding is beneficial to healthcare organizations because of the relationship of coded data to financial reimbursement for services. So the coding compliance plan should include the following components: A policy statement regarding the commitment of the organization to correctly assign and report codes, the source of the official coding guidelines used to direct code selection, and the identification of who's responsible for code selection. We must also provide the procedure to follow when clinical information is not clear or specific enough to assign the correct code. Hint, query, specific or a specification of policies and procedures by care setting, whether that be ER, outpatient, inpatient, and then applicable reporting requirements mandated by specific agencies, including where payer-specific instructions can be found. So, formal policies and procedures must be in place to provide instruction in the entire process from the provision of care through the submission of claims. The coding compliance plan should include the following components: procedures for correction of inaccurate code assignments, areas of risk that have been identified through audits and monitoring, and defined plan for audit and review, and corrective actions outlined for identified problems. We must also provide identification of essential coding resources available and used by coding professionals. We must also outline a process for coding new procedures or unusual diagnoses, a procedure to identify any optional codes gathered for statistical purposes by the facility, and clarification of the appropriate use of external cause codes. We must also determine appropriate measures for resolving coding or documentation disputes with physicians, because it happens. The coding compliance plan should include the following components: a procedure for processing claim rejections, a statement related to the fact that codes will not be assigned, modified, or excluded solely for the purpose of maximizing reimbursement or avoiding reduced payments. Also, that clinical codes will not be revised merely because of either a physician or a patient request to have the service in question covered by their insurance. If the initial code assignment did not reflect actual services, the codes may be revised on the basis of documentation. We must include a statement on the use and reliance on encoding software. Coding staff will be skilled in the area of records and proper assignment of diagnostic and procedural codes, not dependent on or relying solely on a coding software. Medical records are analyzed, or they must be analyzed, and codes selected only with complete and appropriate physician documentation available. Efficient coding guidelines state codes are not assigned without supporting documentation from the provider, and the entire record should be reviewed. Key clinical documents. The official coding guidelines indicate complete and appropriate documentation be reviewed when assigning diagnostic and procedural codes. No external rule or regulation exists that outlines or defines specific documentations required to be complete or appropriate for coding. As a part of the compliance plan, the organization should define what key clinical documents are required based on the care setting and type of record. And the reason being is because different settings and types may have different requirements. Okay, so the last concept in this chapter is going to be about coding compliance education. So ongoing training needs to be a requirement of employment, and testing is encouraged to measure the success of training. Referring to the definitions of fraud and abuse, the idea of what providers and organizations know or should know about coded data and billing practices should be the aim of ongoing education. Prevention, detection, and correction are the goals of a successful coding compliance program. I hope that you found this chapter summary to be helpful. And if you have any questions, please drop them below in the Q&A forum for Domain 4. Thank you.